Hello, welcome to our Health Matters webinar, Medicare for All, the Next Big Policy Debate. I'm Michelle Levander, Director of the USC Center for Health Journalism. Thanks for joining us today. It's been an active week for healthcare. Call it March Madness for policy wonks. The Trump administration is now telling the courts it favors scrapping all of Obamacare. House Democrats, meanwhile, are seeking to strengthen the Affordable Care Act through a new legislative package. And a U.S. District Court judge struck a blow against the signature Trump administration move, blocking the ability of two states to impose work requirements as a condition for receiving Medicaid. In case that didn't seem dramatic enough, it's against that backdrop that we'll be discussing a complete overhaul of our healthcare system, otherwise known as Medicare for All. No health policy idea has made a bigger splash or generated more buzz lately than the idea being advanced by several Democratic candidates for a single-payer healthcare system. Critics argue such policies would bankrupt us for a very long time. Support for such a measure is divided along partisan lines, and some Democrats see this as a next key step for America. In this webinar, we'll ask our experts to explain the differences between Medicare for All and Medicare for Some. We'll talk about strategies for reporters to inform their audiences about what such changes could mean in their communities, and we'll reflect on the likelihood of success for what is being billed as a dramatic new chapter of health reform. Here to help us understand all this, we have three leading experts. Joanne Kanan, Executive Healthcare Editor at Politico, Dr. Adam Gaffney, President of Physicians for a National Health Program and a co-chair of the Working Group on Single-Payer Program Design, and Benedict Ippolito, a research fellow in economic policy studies at the American Enterprise Institute. This webinar is offered thanks to the generous support of the Commonwealth Fund and the National Institute for Healthcare Management Foundation. You can tweet about this webinar at the hashtag Medicare for All. We'll be hearing from our panelists first, and then we'll turn the webinar over to our audience for questions. Because we have several hundred people on the call, we'll ask you to write your questions into the control panel of GoToWebinar. You can write us there if you are experiencing technical problems as well. We will be archiving this webinar and all of the PowerPoints, which you can find at centerforhealthjournalism.org. Now, let's turn to our speakers. Joanne, why don't you get us started and provide us with the lay of the land when it comes to Medicare for All?
I wanted to start by talking about three terms that are often used interchangeably. I think it's important we understand them because they're not the same thing. And then I'll talk a little bit about why we're talking about Medicare for All. You can see the slide here, Medicare for All, which in Washington we just shorthanded as M for A because we shorthand everything. That is one form of a single payer plan. There are other ways you could get to that. So it is the dominant one that people are talking about in DC now. It does not necessarily, and even within talking about Medicare for All, people don't always talk about the same thing. It does not necessarily mean opening up the current Medicare system. It could be, as the major piece of legislation is, creating something new called Medicare and opening that to everybody. There are also proposals that would gradually open Medicare through various buy-ins or their various alternatives. So that's Medicare for All. Single payer means Medicare for All is single payer, but not all single payer ideas are Medicare for All. That just means there's one payer, usually the government, and there could be a Medicaid option. There could be a variety of options that are paid for by the government. A Medicaid buy-in, a Medicare expansion, more ACA. There are all sorts of ways you could get to that. Those are, and the universal coverage. That's the goal, is covering everybody. And there are many ways in many European models, they're not all the same. So you can get to universal coverage in many, many different ways. And I would argue that in order to have it be universal, it also has to be affordable. So just make sure as you interview people and you talk to people and you think about this, that you're not confusing ends and means, and that you're not using terms interchangeably that are not the same things. And also, none of this means free. It can be free if Congress decides to make it free, but many of the countries that have single payer, people do pay, they pay less, way less than Americans do, but there are fees. Why we're talking about it is because it has gone from an idea that was considered fringe is too strong a word and too insulting a word, but it was on the edge of the dialogue. It was not a mainstream part of the conversation. It is very much a mainstream part of the conversation in Washington and many of the states and the presidential campaign right now. We are talking about universal coverage. We are talking about Medicare for all. And we are talking about it in a, nobody expects it to become law in the short term, but it has changed the dialogue about where we could go as a country, and it has also united people on the industries, the healthcare sectors that don't always agree. They're fighting about drug prices, they're fighting about surprise bills, but they have unified to defeat this before it ever gets started. The advocates say it's fair and simple, and we'll hear more about that. And the critics say it's expensive and coercive, that everybody has to have it, whether they want it or not. So I think that's probably all I need to say right now, and then we can turn it over to our two experts who can tell you a lot more, and then we'll come back and talk about some story ideas later, that how you can take this home and cover it in your community.
Thank you, Joanne. We're going to turn now to Adam. What do you hope to accomplish with Medicare for All, and how does this represent an improvement on what we have now?
Great. Well, first of all, thank you so much for having me on this call, and thank you to everyone who's joining it, for listening in. So I am going to be basically making the case for Medicare for All, so that people are familiar with the sort of main reasons why people advocate for this as a policy. And what I'm going to be saying is describes the bill in the House, the Medicare for All bill in the House, the Medicare for All bill in the Senate, and as well as Physicians for National Health Programs proposal. And there's some differences, but there's more similarities between those. So I'm going to give you 4 reasons over the next 10 minutes, 4 key reasons, but there are others. So reason number 1, uninsurance. The problem, one major problem in the U.S. healthcare system today is uninsurance. And as you can see in this figure, which documents the fall in the proportion of the country that is uninsured, you see that there have been 2 big points of progress. One moment in the 1960s, that's from Medicare and Medicaid, when uninsurance rates fell. And then again, after 2014, you see the rate of the proportion of the country uninsured fall dramatically after the implementation of the Affordable Care Act. But that being said, there are still a large number of people who are uninsured, 29 million in 2018. And the number of the uninsured is expected to rise moving forward, even without any action on part of the Trump administration. Now, that's a real problem. First of all, it hurts the most disadvantaged people in the country. People who are uninsured are more likely to be poor, more likely to be near poor than not poor. People who are uninsured are more likely to be Hispanic or Black as compared to white race. And this has clear health impacts. Just to give the most dramatic example of that, is the question of life and death, and a synthesis of the literature that was published 2 years ago in the Annals of Internal Medicine found that overall there seemed to be a relationship between being covered and not dying, and basically found that the uninsured are more likely to face mortality as compared to the insured. And in some ways that's not surprising. We know that modern healthcare is helpful, and not having it is not good. But I want to, so how would that problem be solved? Pretty straightforward. The problem of uninsurance in our current system would be solved by a single payer system because everyone would be covered by it. It would be a universal insurance plan that covered every resident in the country. But that's not the only problem that single payer is designed to solve. The next problem I want to talk about is underinsurance. So this is a picture of a headline from a satirical newspaper, The Onion, and the headline reads, "Company's HR manager really pushing infant deductible healthcare plan." And the gag here is that your boss has a new insurance plan and it works everywhere and you can use it for anything. There's only one catch. You have to pay 100% of the costs out of pocket. So it's a joke, a nerdy joke, to be fair. But there's a kernel of truth behind the joke, which is that deductibles have been rising over the last decade. Deductibles for people who get their insurance through their employer has approximately tripled, as you can see here. But if you get your insurance through the ACA marketplaces, which I have to say are better than what preceded them, but nevertheless, you'll see that the deductibles are even higher in the ACA marketplace plans. People with very low incomes have somewhat lower deductibles, but people even with sort of middle incomes, working class people are facing these kinds of deductibles. So the silver plans, the most commonly purchased plans, the family deductible for 2018 was over $8,000. And keep in mind that one study found that the average U.S. family only had $5,000 in liquid assets. So the consequences of this are that people are what we call underinsured increasingly. This is defined by researchers as basically being having insurance, but having a very high out-of-pocket burden of costs, whether in terms of deductibles or copays. And so even though we've made progress on uninsurance, things are actually getting worse when it comes to underinsurance. And you can see here that the proportion of the nation that's underinsured has risen over time. 44 million people were classified as underinsured in 2018. Now, the consequences of being underinsured, well, it's not quite as bad as being uninsured, but you can see in this figure that the underinsured are much more likely to be contacted by a collection agency because they're accruing medical debt. You can see here that overall as a nation, a substantial proportion of the country continues to say that they are not getting care they need because of cost. 35% of non-elderly adults in 2018 didn't get needed care due to costs. And that's better than where things were before the Affordable Care Act was passed, as you can see, but it's more or less the same place as we were 15 years ago. Now, this has medical consequences, and this is my main interest coming at this as a healthcare provider, as a clinician. So, there's been some studies that said that basically looked at, well, what happens when somebody is transitioned from a traditional low deductible plan or no deductible plan into a high deductible plan. So, among people with diabetes who get transitioned into a high deductible plan, they delay care they need for cardiovascular disease. They are more likely to delay care in terms of seeking care after developing symptoms. They have a 2-month delay before getting their first diagnostic test and a 3-month delay before their first procedure-based treatment. A similar story emerges for women with breast cancer. This is just looking at middle-income women, so not even poor women. Middle-income women who had transitioned into a high-deductible healthcare plan delay getting a breast biopsy, delay getting chemotherapy even. So how would single payer solve this? Well, pretty straightforward. Both the bill and the bill in the House and the bill in the Senate do not have copays, deductibles, or coinsurance, which sounds to an American audience like a little bit, utopian and impossible, but this is basically how things work in Canada and the UK, with exceptions for some things. There's no copays or deductibles for doctor visits or hospitalizations. Reason number three, people can't keep their health insurance coverage in the United States if they want it. So I won't go through all the numbers, but basically people change plans very frequently, involuntarily, because their job changes, because their employer changes their options. Discontinuity. And that's even more true in recent years than it previously was. And these sorts of disruptions in coverage cause disruptions in care, people changing prescription drugs or changing doctors because their plan changes. So this problem of discontinuous coverage would be solved under a single payer system because you'd have the same plan from birth to death. Finally, reason 4, and I apologize if I'm a little bit over, we need to pay for all that, right? We need to have a way of covering those nice sounding things I just mentioned. And so the way we do that is by reducing administrative waste. Because of our multi-payer system, the US has a extremely high burden of administrative spending. 31% of our healthcare dollars go to administration in the US versus 17% in Canada. The overhead of public programs is lower than private programs. It's around 2% in Canada, 2% for traditional Medicare, whereas private insurers have 12% overhead and profits. Hospitals in the U.S. spend a quarter of their revenue on administration and billing because of our complicated multi-payer fragmented system, double the proportion of Canadian and Scottish hospitals. One estimate puts the savings from administration, from audit, from billing and waste and the insurance industry and in hospitals and physicians' offices at $500 billion a year. So that's how I'll conclude. Problem number 4 is we need to control costs, and the way we do it is through low overhead, more efficient insurance. So thank you very much.
Thank you, Adam. Ben, you don't paint quite as rosy of a picture of Medicare for All. You have concerns about its impact. What might happen if this were to become law?
Well, that's the big question. Thank you, everyone, for coming, and thanks for having me. My goal is to provide a slightly different perspective on that question, namely the perspective of someone who I think largely agrees with many of Dr. Gaffney's underlying motivations and goals, but perhaps isn't quite as bullish on Medicare for All. And so my goal is to outline some of the concerns that one might have with Medicare for All becoming law. What kind of questions, what kind of trade-offs might be worth discussing? And I think a very useful place to start is to emphasize that some people are going to come at this debate from a very different perspective. So namely one where you're not particularly over the moon with the current Medicare program as it is. So in particular, Medicare is on a very concerning fiscal trajectory. If we look at estimates from the CBO, Medicare is eating up an increasingly large portion of federal spending, increasing by about 30% over the next 10 years. Unfortunately, unless we increase taxes by a similar amount, at least enough to cover this, Social Security, and other programs, then we're going to have to make some trade-offs here. And as much as I like healthcare, and I do, I also like schools, and I like infrastructure and other things. And so there's bipartisan concern about the costly nature of the Medicare program as it is. And so I think it's useful to understand that some people are going to come at the idea of expanding Medicare from a very different angle, namely one where we're already maybe concerned about where Medicare is going as it stands. And so the vision that Dr. Gaffney lays out is one where we would, of course, be expanding a much, much more generous version of Medicare. And so from the baseline, I think there are going to be two very, very different camps here. Now, we're here to talk about Medicare for All, so I won't talk about Medicare as it currently stands for this whole time. And so for the rest of the time, I do want to talk about, suppose we get past that hurdle, as we look forward to expanding this very generous version of Medicare, what exactly are we going to have to think about in terms of practical challenges and trade-offs that we'll need to consider? So I'm going to go through a few, and of course, as Dr. Gaffney's list was not an exhaustive list of the purported benefits, this is not going to be an exhaustive list of the challenges. But here are a few things that I think are worth thinking about as you cover this issue. So first, how is Medicare for All really going to achieve the lower payment rates that it relies on? You'll often hear that administrative savings account for all of the cost savings in a Medicare for All plan. Scores of these plans simply dictate that that's not true. Indeed, most of the savings come from lower payment rates. So in these plans, rather than paying private rates, everyone instead pays Medicare rates. It's important to note that's a very, very big transition. Right now, for example, private insurers on average pay hospitals about twice as much as Medicare. And so when you think about this question, I think it's important to understand that much, much smaller reductions in payment rates have historically been a huge political challenge. So how is Medicare for All going to succeed here, where so many other proposals that were much more modest have run into roadblocks? And building on that, how is healthcare going to look different? We're no longer going to have 150 some odd million people paying about double of Medicare rates. That's really nice for the current Medicare system because, of course, it subsidizes facilities, equipment, innovation, and so on. So these large payment reductions are going to have effects. And so what kinds of effects are they going to have? Are they going to affect our innovation? Are they going to affect our investments? Which of these trade-offs are worth making? And I don't want to assign any sort of normative statement here. Indeed, I think there are a whole bunch of trade-offs that we should be making in healthcare where we trade off less innovation, say, for lower prices. But Medicare for All is envisioning very large trade-offs there, and so it's something to push on. Thirdly, how is the federal government going to raise enough money to actually accomplish this? No matter how you do this, this is an extremely expensive proposal in the ballpark of $30 trillion over about 10 years. That is, the government needs to raise about $30 trillion in taxes. How are we going to do that? that's a fairly Herculean effort. And so I would push for specifics here. What kind of taxes are going to be used to pay for this? Are they going to actually fund the whole program? If not, are we going to be worried about the debt blowing up? Finally, Dr. Gaffney talked about the advantages of continuity in care, and I agree with him. But of course, we're also talking about very large disruption in the kind of insurance that Americans have. 150 plus million Americans have employer-sponsored health insurance they like. Think back to the Affordable Care Act and the "you like your plan, you can keep it." We're talking about disruption that would exceed that by magnitudes. And then finally, one thing that I think is one of the most important things to consider that is very underappreciated is what happens if the plan evolves into something that people don't like? What mechanisms are going to be in place that Americans can use to actually influence this program? And so those are some of the questions that I think are worth asking. And with the rest of my time, I'm going to go through just a quick sketch of the kinds of reactions I have as somebody who's a bit more skeptical, I think, than Dr. Gaffney certainly about the future of Medicare for all. So let's start from the top. How is Medicare for all going to achieve lower payment rates? I think it's fair to say that there is very little historical precedent to suggest that it can. We would have to lower payments to providers by about $5.5 trillion over 10 years. We cannot assume that away by saying there's going to be administrative savings. Yes, there will be some, but it won't be nearly enough to offset the extra spending. And so I point to a recent example. The Trump administration recently released a non-binding budget, which included about $500 billion in Medicare cuts, where cuts is in quotations there because many of these cuts were bipartisan proposals like site neutral payments. If hypothetical reductions of that size are going to draw outrage, then can you imagine what $5.5 trillion worth of cuts is going to draw? Secondly, how is healthcare going to look different? Well, if there's one thing that the research tells us, it's that healthcare changes when returns change, innovation changes, and so on. So I would actually point to the fact that the issue with current healthcare in America at in its current state is not that we don't have options to lower costs and options that have been long vetted and are well motivated and are very specific. It's that it's hard to do that. And so simply assuming that we're going to be able to do that at this extremely large scale is, again, it's something that should be met with, I think, some skepticism. Finally, pushing a little further, how's the federal government going to raise enough money to accomplish this? Again, $30 trillion over 10 years. Even if you look at proposals that include a host of hypothetical tax increases, they come nowhere close to financing these systems. You look at the Bernie Sanders campaign proposal, I believe the Committee for the Responsible Federal Budget had it raising only $11 trillion. That's $20 trillion short of financing the plan. And so if we can't raise the money in a hypothetical world, it seems very hard to imagine that we're going to be able to do that in the real world. And again, disruption without going over this too much, I would say that the Affordable Care Act provides a nice lesson there. And I want to wrap up, though, again, on this point that I think is very much underappreciated, namely, what happens if the plan evolves in a way that we don't like? This is a little bit of a pitch for the value of choice. So choice allows consumers to vote very quickly and very directly with their feet. Elections are much less direct and they're much slower. And importantly, sometimes your candidate isn't going to win. And so I'm going to leave everyone with one thought experiment, which is suppose Medicare for all existed under the Trump administration. If we think about what the Trump administration's actions have been in healthcare, we think about Obamacare sabotage, eliminating the individual mandate, reneging on promised payments to health insurers to participate in the exchanges, literally an ongoing lawsuit to repeal the entirety of the Affordable Care Act, Medicaid work requirements, Title X rules. These are trying to restrict the ability for things like Planned Parenthood to run or operate. Is that the kind of Medicare for all proponents are envisioning? I would suspect no. And if the answer is no, then again, I would really emphasize that there's a real value to choice. And so one of the unifying themes that I think some Medicare for all, skeptics, if you want to call them that, would share is choice has real value. Even though I agree with Dr. Gaffney that it introduces some extra costs, like administrative costs, there are real benefits. And so I'm going to leave it with end on that thought experiment and turn things back over.
Thank you very much. So just want to tell our audience that you can send us your questions now, and we will ask our speakers on your behalf. I wanted to start us out with a question for Joanne. If you're a reporter in a local market, how might you cover all this political jockeying in Washington about this? What would be a good way in or two?
I think that the speakers talked about a couple of things they brought up are important. I think the idea of underinsurance, which Dr. Gaffney talked about, I think that's a growing problem that was supposed to have been addressed by the ACA, and for a variety of reasons, including policies, but not only because of policies by the Trump administration. I think sort of getting the lay of the land in your community. We're used to thinking about it as covered or uncovered, but there is this gray middle, and of people who might not even know how underinsured they are until they get sick. And we also have these new plans on the market now that the Trump administration is pushing, and the association health plans and these short-term plans. And I think how people experience those, and I think how the obstacles people encounter when they get sick and find out that their insurance isn't really worth a lot, I think that is going to affect how people welcome or fail to welcome these ideas about universal coverage and Medicare for all. I think also looking the cost shifting that Ben discussed is, it's easy to say Medicare costs this and private insurance or private healthcare costs that. There is a lot of cost shifting. Every hospital, every community, every county has a hospital. Well, some of you are in rural areas that no longer have a hospital, but most of you have a hospital somewhere nearby that you cover. And finding out, what does Medicare cover and what doesn't it? That's a legitimate question, as they nobody thinks that Medicare for all is going to pass in the next 2 years because the Senate, Trump would veto it, and the Senate is Republican. It may never pass in the form that is currently being discussed, but it will be part of our dialogue, and it will shape how we talk about expanding coverage, even if the Bernie Sanders approach doesn't become law in our lifetime or in the next 10 years or 20 years or whatever. I also think that the politics shifted a little bit this year, just this week, because Medicare for All was soaking up a lot of the political oxygen. And I think that you locally should also look at how, the Obamacare wars broke out again this week. They broke out again in the courts, they broke out in the White House, and they broke out in Congress. I think with the ACA now being sort of threatened again, it will also focus, and this is where states and communities can do things without Washington. What is your state doing to strengthen the ACA, to protect the coverage? Is your state more likely now to do its own mandate? Is your state more likely to do some kind of market stabilization? I think that the conversation this week shift, and this is not an administration with a really long attention span. Things change all the time. But I think this week also, while we're talking much more about Medicare for All and its variants, I think this week also put the ACA as a local, not so much a local community can't do as much, but a state can do things to shore up the ACA or to undermine the ACA. So I think that is something that you should also keep in mind. So talk to your local hospital about cost shifting. Talk to people about what their experience as being insured or underinsured, and do they even know the difference, and how they find out. And the sort of lofty political debate about Medicare for All versus not Medicare for All versus this renewed, what are we going to do about the ACA in the short term?
Thank you, Joanne. So we have a question from Barry Schatzman for Ben, and I'll also ask Adam if he wants to reply to this as well. But his question is about the 32 trillion number that you cited, Ben, and he asks, how much are we paying now, and how might Republicans provide health care to everyone? What should we do now, considering the problems that were previously presented?
That's a good question, and I think it highlights one of the key definitional issues that does arise with this issue. So the number I was citing is a number that is how much more would the federal government have to absorb in terms of healthcare spending if we enacted Medicare for all. So this comes from Charles Blauhaus's estimate of the Bernie Sanders plan, and it's very similar to an estimate from the Urban Institute. And so this is different than saying literally the United States would spend $32 trillion more on healthcare. That is completely separate. This is mostly reflecting that the federal government would have to take over spending that was previously done by the private sector and instead would now be done by the government. That still means that the federal government has to actually raise that money, and they need to propose about $30 trillion in taxes over the next 10 years. And so that's where, again, just practically speaking, there's going to be a big challenge. Now, as for what are Republicans going to do, that's a very good question because just about, a year and a half, 2 years ago, Republicans seemed like they were on the precipice of actually repealing and replacing, as it was called, the Affordable Care Act. Well, what came out of that was a very, very muddled process with very unclear goals that, frankly, I can't sit here and tell you that I exactly know what the goals were, and nor can I tell you what exactly the goals are of the Republican Party formally. I think that for somebody who would be more of a pragmatic center-right person, which is how I would think of myself, I think realistically we're going to have to start thinking about things that actually don't necessarily look that different than something like the Affordable Care Act, but perhaps has different regulatory structures, different financing schemes around them. So namely, I'm thinking of things that might be more fiscally sustainable than expanding Medicaid and saying the federal government's going to pay for it forever, or programs where the federal government simply absorbs every price increase that occurs on the Obamacare exchanges. Now, having said that, I don't think that that's anywhere near where the current Republican Party is. And so it's a bit hard to actually answer the question of what exactly are they going to do. I think we're going to have to wait and see.
This is Adam Gaffney. I'll follow up on that. I think the question is a good one, which is, what do we mean when we say that Medicare for all would cost X dollars? And so the number that was provided, the $32 trillion figure, does, as Benedict said, come from the Mercatus Center study. And one interesting thing about that study, which was performed by someone who is ideologically on sort of the opposite end of the spectrum of where Medicare for all is coming from, is that he even estimated that overall healthcare spending would actually fall by $2 trillion over a decade. So these are two different things. One is, how much do we spend on healthcare as a nation? Question one. And even according to that Mercatus Center report, we would spend less as a nation on healthcare by $2 trillion over a decade. Question two is, where is that money coming from? Is it coming from people's bank accounts for premiums, copays, deductibles, or is it coming through taxes? So it is true that under single payer, a lot more money would be coming through taxes, but overall, less money would be spent as a nation collectively. I would also mention one thing that many people are not aware of is the fact that we already finance our healthcare system mostly through taxes already. About 2/3 of every healthcare dollar is taxpayer financed. So we're not talking about financing every dollar of healthcare right now that's being spent. We're talking about financing the remaining private sources with public sources. So it's an important distinction.
Thank you to you both. I have a question from Sarah Hansard. She says, Dr. Gaffney, what are your thoughts about cost shifting by hospitals and doctors to employers? Do you agree with providers that Medicare rates are too low?
I think at the end of the day, as we transition to a single payer system, it is not realistic to expect that we are going to reduce substantially overall spending on healthcare providers. Okay. I do think, and we have a little disagreement here, but I do think that the administrative savings will be sufficient to cover the costs of covering the uninsured and upgrading coverage for other people. And so I think my vision of this moving forward is that, look, physician salaries, you can, some people, I understand the doctors are well paid, but it does account for 8% of overall healthcare spending, approximately. So you don't need to reduce physician payments, salaries in order to make this happen. You may want to, but you certainly don't have to make this work. Likewise, on the hospital side, I think that hospitals can certainly downsize on their billing departments, which, again, billing and administration is a quarter of hospital revenues, double the proportion in Canada or Scotland. So I think that the hospitals can downsize on that part of their operations. But apart from that, I don't think we should think about this as sort of squeezing providers and giving them less money to work with in terms of providing actual health care. Now, not everyone thinks that way, but I don't think it's possible to sort of achieve single payer on the cheap, so to speak. That being said, over time, a single payer system does give you unique levers to control the growth in spending. And we've seen that, in terms of the comparative rates of healthcare cost growth in the United States compared to other countries. If you go back far enough, we spent the same and we just grew a lot faster. So there's no question in my mind that public financing allows you to control cost growth over time. But that's different than sort of suggesting that we're suddenly overnight going to sort of, massively slash the amount of money we're spending collectively on healthcare.
Well, I guess I would respond by saying that's exactly what Bernie Sanders is proposing. That's exactly what is generating the numbers that you just cited from the Mercatus study. Namely, if you don't include any payment reductions to providers, then, of course, total healthcare spending would not fall by $2 trillion every year. As you know, it would, of course, increase by at least $4 trillion in that same exact score. So I guess it seems a bit hard to reconcile. And I guess for those covering this story, I would emphasize the following, that if it sounds a little bit too good to be true, then it probably is. Administrative cost savings have been scored. We understand how large they are, and they are nowhere near large enough to cover the kinds of coverage that is being proposed in a Medicare for All plan. And it's totally fine that Dr. Gaffney disagrees with me on that point. I would simply like to see any evidence that supports that statement. As of right now, the evidence that he supports simply indicates that that's not even remotely close to true.
Just Joanne, I want to just point something out is the bill in the House is free medical care and including long-term care. There's no co-pays, there's no premiums, there's no deductibles, there's no nothing. The CBO hasn't scored it, the Congressional Budget Office. It's not that they're always right, and it's not that they have a crystal ball that's perfect, but it is a useful marker for the debates in Washington, and we don't have that yet. It is also possible that you do a variant of that bill, that they decide that it would be means tested, that it could be, that poor people would pay nothing and middle class people would pay little and rich people would pay a lot. I mean, they're all sorts of variants. So when we talk about, we just don't know the revenue piece. It's sort of a revenue piece TK. They're going to talk about that later in the House side. They haven't said how they have said it would be free in the current version. But as this debate evolves over time, there's no predetermined. You could make that. You could assemble the numbers in lots of different ways. If we ever got to the point where there wanted to be a political compromise and they had to agree on budget numbers, the budget numbers would be sort of a jigsaw piece, and you negotiate. We're nowhere near that point where we're going to sit down and actually have Republicans and Democrats sit down and figure out the best way to pay for this. But it's still somewhat. It's not fleshed out on the economic side. And as you reporters talk to people about it, and those of you who are in states that might try to do a public option or a Medicaid buy-in or a single payer variant of its own, those are really important questions. How are you going to pay for it? Because when states have tried to do something, what stopped it hasn't been there's been affection for the idea until the money came. The money is what stopped it. The inability to finance is what stopped single payer in Vermont. It's been a problem in California. The Colorado referendum, I think it was 2 years ago, maybe it was 3. I think it was 2 years ago. Was also partly because of money. I mean, it's a big obstacle, and until everybody agrees on A, that you want to do it, and B, how to pay for it, and no one's reached that point of unanimity.
So we've had a lot of questions about cost. We have a question from Gene Durio about fraud. He says, fraud is widespread in Medicare. more than 60 billion a year and increasing. How do we prevent fraud in a new system when we can't do it now?
Well, I can take a stab at this. I don't know the exact fraud numbers, but my suspicion is that while I certainly agree that there's fraud in the current system, we certainly see very large settlements in the past. We have seen, I believe, HCA was the hospital system that was fined by, I believe, a total of $2 billion by Medicare. So there has been substantial fraud in the program. Having said that, while that's an important thing to work towards, I sort of think of that as being I suppose this is like the Republicans' version of administrative cost savings. Waste, fraud, and abuse has this magical funding capabilities. I I don't know that Medicare for All necessarily would solve that problem, but I also don't necessarily know that it would make it worse. I suppose it might make it more tempting, but I don't know that that's necessarily my first order issue, though I'm certainly curious what Dr. Gaffney has to say.
Yeah, I mean, I think there's a couple good points there. I mean, one, I think that yes, there's no magic wand here to suddenly make fraud disappear. I think that you could make a case that single payer gives a little more transparency in terms of where the money is going when everyone's in a single sort of pool. But I mean, there are, I think, some bad actors here that traditionally have overcharged that I think that a Medicare for All system would help push out. I mean, personally, I think the HCA example is a good one. That's a for-profit hospital chain that has had multiple settlements and has had a string of legal complications for sort of bad behavior. And you also have seen, bad behavior on the part of the private insurance industry, right? So the Medicare Advantage and its predecessors have overcharged and played games in an enormous number of ways, making patients seem sicker than they are, trying to avoid sicker patients, upcoding, they call it. So there's a whole, literature on the kinds of games that that those plans have played. So, and as I showed in one of those slides, traditional Medicare has an overhead of around 2%. The Medicare Advantage plans, according to a GAO report from some years back, have a overhead including profits of closer to 12, 13%. So there's, I would agree there's no sort of magic bullet when it comes to fraud, generally speaking, but I think that Medicare for All, by pushing out some of the profit motive, could help to achieve savings and save costs.
We have a question from Dana McMurtry for Ben. Can you expand on what you mean by choice? In the private sector, choice of providers is limited by network size. Choice of plan is somewhat meaningless because they aren't much different in their interface with members. Or do you mean choice of health benefits, in which case generosity depends on what one can afford?
Well, that's a very good question. I think when I think of choice in this context, I'm emphasizing choice of insurer. And I want to preface this by saying that I'm keenly aware that there are certain parts of the country where we have trouble generating choice in health insurance and in, frankly, just about everything else. In small towns, it's hard to get a number of grocery stores to compete with each other in the same way that it's hard to get health insurers to compete with each other. But focusing on areas where there's a bit larger population centers, my point is to say that if you don't like your plan and if there's something going wrong, then at least having an outside option allows you to have an escape valve there. And it's important to emphasize that in economic speak, we might say this outside option is a threat point. And what that means is that even if you don't switch, the very fact that you have the opportunity to do so implores the insurance companies to behave as if you might actually leave. And of course, I'm very much aware that everybody doesn't change insurance plans every year, but of course, that threat would be part of the reason that doesn't happen. So I'm very much thinking about the choice of plan or the choice of insurer that's available to somebody, that's available if something happens where you decide that you don't like the kind of insurance that's being provided to you.
I might jump in and say that I think that choice of insurance plan is mostly useless, right? What people care about is choice in doctor, choice in hospital. They want to make sure they can get the care they need, get the drugs prescribed that they need. I don't think people really care as much about whether Cigna or Aetna is the one who's covering them. Um, right now there isn't real choice. Your employer changes plans and then you change plans. You lose your job and then you lose your coverage. You get divorced, you can lose your coverage that way as well. I mean, the current system doesn't give choice. And even when people do have choices, it's a choice between a number of often faulty products. I think what people much care about a lot more is choice of provider. And I think one key advantage and selling point of a Medicare for All system is that it would, in fact, end insurance networks so that there wouldn't be in-network and out-of-network. There would be essentially all the nation's providers in one big network. And I think that's something that people, like the sound of.
One quick follow-up. I think it's reasonable. Those are reasonable points. The one piece of evidence I would point to is the Medicare Advantage market, which of course has its problems like every other market. But one of the things we've seen over the last 15 years is a large shift of Americans from traditional Medicare to Medicare Advantage. This is where private firms compete for customers. And what we've seen is seniors are willing to give up the extremely broad network that is traditional Medicare, namely where basically everybody accepts Medicare fee-for-service, in exchange for more narrow plans that are Medicare Advantage plans, where they're slightly more constrained on choice, but in exchange for that, they get a variety of other services. And so there are these trade-offs that I think a lot of people are willing to make. The only other thing I'd say, I am by no means a proponent of employer-sponsored health insurance. I think the way we subsidize it is quite problematic, but I don't think it's quite as bad having your employer choose your plan as you might think, just because in most cases, employers like having people who are happy. And so if HR is getting a lot of complaints about the plan, the fact that they might change is not crazy to me. But I take your points as well put.
So we have a question from Mac McCarthy who says, I'd appreciate hearing the speaker's views on a Medicare opt-in program where pre-65s could elect Medicare in lieu of employer-provided or individual insurance, assuming these individual plans paid the full cost of Medicare A, B, and D.
I'm happy to take a first stab at that. I don't think that the buy-ins are going to really solve the problem of the American healthcare system. It's basically a public option, which is being described, and there's different varieties of it. And that's, one based on Medicare benefits is one option. But what would it fundamentally do? I mean, it would give some people one more option of an insurance plan to buy. That plan would still have many of the weaknesses of the current Medicare program, including copays and deductibles and limited benefits. It wouldn't have the administrative savings that I've talked about a bunch that you achieve when you transition from a multi-payer to a single-payer model. And even for the people who are already covered, they wouldn't see any benefit in terms of their the flaws in their current insurance. So I think it could help some people, but I think it's not the solution to the big injustices and dysfunctions of our healthcare system.
Yeah, buy-in has some features that I think, in some sense, seem appealing, but on the other hand, don't necessarily satisfy almost anybody at the end of the day. Interestingly enough, so on one hand, buy-ins are quite expensive if the enrollee actually has to foot the cost of the true cost of having Medicare, and that's especially true when we assume and know that there's going to be very strong selection into those plans, namely people who use a lot of healthcare. And so it's going to be quite expensive to be enrolling in those plans. And the second thing is, to where this doesn't really solve one of the fundamental things that Dr. Gaffney, sort of sees as problematic about the U.S. healthcare system. It similarly doesn't solve one of the fundamental problems that I see with the Medicare system as it currently is, which is we've got this problem that's systematic about the funding structure of the system, the fiscal trajectory. And so, again, I look at that and say, geez, I would really like to go back to this Medicare program and solve this before we even start talking about expanding it, even as it currently stands.
We have a question from Carl Brimmer who says, other countries have implemented single payer systems. Has anyone called Canada, Australia, or Belgium to see how they have successfully paid for their systems?
So I'm, again, happy to get started with that. I mean, right. So overall, those nations over time have done a better job of controlling their healthcare costs. And why is that? Well, Medicare sort of single payer systems give you more tools to control cost growth over time, whether that's in rate setting, whether that's in controlling capital expenditures. We can talk about a few different things. And certainly, as I said, they spend a lot less of their money on healthcare administration. How do they finance it? They finance it through taxes, by and large. Canadian healthcare is publicly financed through taxes. So that means you're spending, more on taxes, but you're spending nothing in terms of premiums and copays and deductibles. And overall, those programs have proven far more financially sustainable over the long term. And they're quite, the citizens of these countries in general are very favorably disposed to those programs. They actually don't want to go in our direction.
Yeah, and actually, one of the interesting things that when I look at cross-country comparisons that I often think of is that there are these countries like Canada, like Dr. Gaffin talks about, that do have more of a true single-payer system. What's interesting is that there are a lot of other countries that spend a lot less than us that actually have systems that are not necessarily that different from us. Managed competition, where you have places like the Netherlands, where the government regulates private insurers that compete against each other. And yet they still also manage to spend a lot less than us. So I don't know that it's necessarily one specific model, but indeed these other countries have been much more aggressive about controlling costs. There's no question about that. I think one of the objective questions that faces anybody as they approach large-scale changes to the U.S. system, be it single payer or some sort of laissez-faire nirvana, is that the United States, for better or for worse, has become an enormously important spender in the healthcare world. Namely, when you think about things like drug spending, we spend about the same as the next 9 highest spending countries put together. And so what does that mean? It means that it's much more consequential for us to think about changes to our program than, say, a very small country like the UK or Canada, relatively speaking. And so that's just simply going to be one of the challenges that faces, frankly, any of these options.
And I would add that not only are we spending more, but contrary to what you often hear, we do not have the best healthcare in the world. We don't cover everybody. We don't cover everybody well. And a lot of our outcomes, some things, if you want a liver transplant, maybe this is the best place in the world to get a liver transplant. I haven't investigated that, but I would believe it if I think that's quite possible. But if you want really good maternal mortality figures, don't look at us. Go to Finland. It's inequitable in terms of coverage, and it's not great in terms of outcomes. And the slogans about best care, which you don't hear as much as you used to, America has the best care in the world, we don't actually hear it because I think there's a greater recognition that our care is really uneven. We do some things really, really well, and we're really lousy at others.
We have a question from Mark Miller for Ben. He says, on the spending by the federal government for the current Medicare program, your chart looks scary, but CBO's projection is that mandatory spending for Medicare, Social Security, etc., as a share of GDP will rise 2 percentage points from 12.9% of GDP to 14.9% by 2028. That's significant, but shouldn't we expect that with the aging of the population?
Yeah, so the demographic shifts are definitely part of this, but it's more than just demographic shifts. There is going to be a with some of these older age programs. There's sort of a bump and then a phase out of the baby boomer generation. But there's also other larger scale issues, namely. We live a lot longer, for example, than when the Medicare system or the Social Security system were first put into place, and so we're covering people for much longer periods of time. These programs may even cover many more things, and so I don't think it's purely a case of demographics, but you're absolutely right that demographics play an important role in the next probably 10, 15 years of spending on those programs.
Can I just throw one quick comment in here about the Medicare question and the sustainability? I think it's worth pointing out that Medicare does cover seniors more efficiently at lower cost than would the private sector. So if we suddenly dismantled Medicare and said we're going to give an equivalent amount of health care to seniors through the private health insurance system, it would actually cost more. So if we can't afford Medicare, that's like saying we can't afford health care for seniors because there's not a clear, less expensive way. Just a sort of way to think about the issue.
Interestingly enough, actually, Medicaid is often one of the under-heralded programs in this country for cost consciousness. Indeed, Medicaid is typically the lowest cost. So I guess the answer to Dr. Gaffney's question is there is one way that's cheaper, is everyone could have Medicaid instead of Medicare.
So, a question for Joanne as we get close to the end of our time together. There's so many competing ideas and numbers connected to all this. Do you have a suggestion for, a reporter trying to figure out what would be the most useful stories for their audience and how to sort through all this in a way that's
I think that, I mean, luckily there's a lot of resources. I mean, obviously USC, the Center for Health Journalism, they have it on their website. They've got a bunch of good things to read. There are other journalism education organizations. Pointer has done work, not recently, but they have done work on healthcare before. The Shorenstein Center at Harvard has done work on healthcare. There's many of you are AHCJ members. I think you're allowed to be happily part of both Center for Health Journalism and AHCJ, as I am. So there are resources out there, and unlike when I started a million years ago, they're online. They're easy to find. You don't have to clip them out and stick them in your desk. And I think really understanding your terms, really getting understanding because sometimes people are using terms loosely because they don't understand them, and other times they're using terms loosely to confuse you. So I think really being confident of what the lexicon of healthcare is really important. And also, as our president famously said, it's complicated, and don't be afraid to push someone to explain more. I mean, I've been doing this for a long time, and I asked what are probably sound like dumb questions, but as we all know, as journalists, there's no such thing as a dumb question. I also think a story I meant to mention before. Physician attitudes are changing, and I think it's really worth exploring that because physician attitudes do influence how patients think and how our society is going to move forward. Most of the interest groups, the hospitals and the insurers and the drug companies, I mean, they're fighting about a million things, but they're very united on this. They formed an alliance to really nip it in the bud, and not just Medicare for all, but the various the more incremental approaches, the buy-ins and the slower rollouts of more public health plans. So I think talking to doctors and the AMA was the ones that back in the 1930s, killed, prevented FDR from trying to complete the New Deal, with the healthcare by calling it socialized medicine. That's really an important, it's a powerful word, socialized medicine, big government. It stopped, it took almost 100 years to get, because it actually predated FDR. It started with Theodore Roosevelt. It took a century to get the ACA passed. But I think talking to particularly younger physicians and why they are more open to something resembling Medicare for all is also a good story and something to understand because they are experiencing all the great strengths and the crazy weaknesses of American healthcare. I mean, it's a great system in many ways, and it's a totally convoluted, crazy system in others. And I think talking to particularly younger physicians can often be really interesting, or the old timers who hated this for years and now have thrown up their hands and say it's the only way to go. So I think that's also talking to the providers about what their experience and how their views are changing is useful and will bring out good stories.
Thank you. Ben and Adam, as people on opposite sides of the aisle, do you have a suggestion for journalists on how to sort through all this?
I was actually going to agree with something that Joanne said. And when you talk to folks, I would push you to make sure that folks are really defining what they're talking about. I mean, as somebody who has those kind of questions asked to me, sometimes it actually makes me think a little bit more clearly and more concretely about what the heck I'm trying to say. And so I very much echo that comment. The only thing I think is a good thing to think about when you talk to folks about this issue on one side or the other is to try and get folks talking about, so what are the weaknesses of the idea that you like the best? It's not something that most folks like talking about, but you might get some illuminating insights. Nobody, I think, thinks that one plan is absolutely bulletproof. So trying to get people talking about what are the trade-offs that you are making, why do you think those are worth making, and trying to flesh that out, I think gives a much fuller picture of the healthcare landscape and how people envision it moving forward.
Yeah, and I guess I'll just conclude by saying, I think one of the key elements to all this is the human factor. How these issues that, I talked about and other people have talked about, how the problems of uninsurance, of underinsurance, drug costs, being switched from plan to plan, disruptions in care, how all these issues are affecting people in your communities, because these are not rare stories. I mean, they're so commonplace, and I certainly hear about them all the time. But until you really report, I think, on the human story, the numbers don't really give you a real sense of the harm that's being done by the dysfunctions of our current system. So that would be my sort of takeaway, that we need to see the human perspective sort of combined with the policy ideas. And I think that's really an important part of it all.
With that, I want to thank our audience for their thoughtful questions and our speakers for their excellent commentary. We are going to end our webinar. We will be archiving this webinar on centerforhealthjournalism.org, and a little later we'll be sending you a survey, which we ask you to complete, sharing both your opinion of this webinar and your ideas for upcoming topics. Thank you so much. Have a great day.